Question 1. The monitoring system demonstrates a 65-year-old female presenting with insidious onset of bilateral knee pain, worse with weight bearing, and relieved by rest. She reports morning stiffness lasting approximately 30 minutes. Physical examination reveals crepitus with passive range of motion, mild joint line tenderness, and no significant warmth or erythema. Which of the following diagnostic and management strategies best aligns with the suspected underlying musculoskeletal condition? Option A. Order a bone density scan and initiate treatment with a bisphosphonate. Option B. Perform a joint aspiration for synovial fluid analysis and prescribe colchicine. Option C. Refer to rheumatology for immediate initiation of a biologic DMARD. Option D. Obtain plain radiographs of both knees and initiate treatment with a non-steroidal anti-inflammatory drug, NSAID, and acetaminophen. The correct answer is A. Order a bone density scan and initiate treatment with a bisphosphonate. Explanation. The monitoring system demonstrates a patient presenting with symptoms suggestive of a musculoskeletal disorder, requiring the PA to differentiate between various inflammatory and degenerative conditions. The professional challenge lies in accurately diagnosing the underlying cause to initiate appropriate, evidence-based management, thereby ensuring patient safety and optimal outcomes. This requires a thorough understanding of the pathophysiology, clinical presentations, and diagnostic modalities for conditions like osteoarthritis, rheumatoid arthritis, and gout, as well as the pharmacological agents used in their treatment, all within the scope of PA practice as defined by NCCPA guidelines and relevant state practice acts. The correct approach involves a systematic evaluation that integrates the patient's history, physical examination findings, and appropriate diagnostic testing to arrive at a differential diagnosis. This is followed by selecting pharmacological management that aligns with current evidence-based guidelines for the specific diagnosed condition, considering patient-specific factors such as comorbidities and contraindications. This approach is ethically and regulatorily sound as it prioritizes patient well-being, adheres to the principles of evidence-based medicine, and operates within the established scope of practice for physician assistants, ensuring that diagnostic and therapeutic decisions are informed and justified. An incorrect approach would be to immediately prescribe a broad-spectrum analgesic without a definitive diagnosis, failing to investigate the underlying cause of the patient's symptoms. This bypasses crucial diagnostic steps, potentially leading to delayed or incorrect treatment, masking more serious conditions, and violating the ethical obligation to provide competent and individualized care. Another incorrect approach would be to recommend a specific disease-modifying antirheumatic drug, DMARD, without first confirming a diagnosis of rheumatoid arthritis, as DMARD are not indicated for osteoarthritis or gout and carry significant risks and side effects. This demonstrates a failure to adhere to diagnostic protocols and evidence-based treatment selection, potentially harming the patient. Finally, relying solely on imaging without a thorough clinical correlation, or conversely, neglecting appropriate diagnostic imaging when indicated by clinical suspicion, represents a failure in comprehensive patient assessment and diagnostic reasoning, which are fundamental to safe and effective PA practice. The professional decision-making process for similar situations should involve a structured approach. 1. Obtain a comprehensive history, including symptom onset, duration, character, aggravating and alleviating factors, and associated symptoms. 2. Perform a thorough physical examination, focusing on the affected joints, range of motion, swelling, tenderness, and signs of inflammation. 3. Develop a differential diagnosis based on the history and physical exam. 4. Select appropriate diagnostic tests, e.g., X-rays, joint aspiration for crystal analysis, inflammatory markers, to confirm or exclude diagnoses. 5. Based on the confirmed diagnosis, select pharmacological management in accordance with established clinical practice guidelines, considering patient-specific factors and potential drug interactions. 6. Educate the patient about their diagnosis, treatment plan, and expected outcomes, and arrange for appropriate follow-up. Question 2. The monitoring system demonstrates a continuous increase in end-tidal carbon dioxide, ECO2, from 45 mmHg to 58 mmHg over the past hour in a patient with acute exacerbation of COPD who is currently receiving supplemental oxygen via nasal cannula and has a stable SpO2 of 92%. The patient is alert but reporting increased shortness of breath. What is the most appropriate immediate next step for the physician assistant? Option A. Assess the patient's work of breathing and consider non-invasive positive pressure ventilation. Option B. Administer a bronchodilator via nebulizer. Option C. Document the findings and continue to monitor the SpO2. Option D. Increase the flow rate of supplemental oxygen. The correct answer is D. Increase the flow rate of supplemental oxygen. Explanation. This scenario is professionally challenging because it requires the physician assistant PA to interpret complex physiological data in the context of a critically ill patient with potential respiratory compromise, while adhering to established standards of care and regulatory guidelines for patient management. The PA must synthesize information from multiple sources, including patient presentation, diagnostic tests, and monitoring equipment, to make timely and appropriate clinical decisions. The correct approach involves a systematic and evidence-based assessment of the patient's respiratory status, prioritizing interventions that directly address the identified physiological derangements. This aligns with the PA's scope of practice and the ethical obligation to provide competent and safe patient care, as outlined by the NCCPA and relevant state practice acts, specifically recognizing the signs of impending respiratory failure and initiating appropriate management, such as escalating ventilatory support or pharmacological interventions, is paramount. The PA's role is to monitor, assess, and intervene within their training and licensure, ensuring patient safety and optimal outcomes. An incorrect approach would be to dismiss the elevated end-tidal carbon dioxide, ETCO2, as a minor anomaly without further investigation. This fails to acknowledge the physiological significance of hypercapnia, which can indicate inadequate ventilation and lead to serious consequences like respiratory acidosis and central nervous system depression. Such an oversight would violate the standard of care and potentially lead to patient harm, representing a failure to exercise due diligence and professional judgment. Another incorrect approach would be to solely rely on the SpO2 reading without considering the ETCO2. While SpO2 is a crucial indicator of oxygenation, it does not directly reflect ventilation. A patient can have a normal SpO2 while being significantly hypercapnic, masking underlying ventilatory failure. This narrow focus demonstrates a lack of comprehensive understanding of respiratory physiology and diagnostic interpretation. A third incorrect approach would be to delay intervention until the patient exhibits overt signs of respiratory distress, such as severe tachypnea or accessory muscle use. This reactive approach is contrary to proactive patient management and the principle of early intervention in critical care settings. The monitoring system provides early warning signs that should prompt investigation and action before the patient's condition deteriorates significantly. The professional reasoning process in such a situation should involve 1. Recognizing and interpreting abnormal monitoring data, elevated ETCO2. 2. Correlating this data with the patient's overall clinical presentation and other available diagnostic information. 3. Considering the differential diagnosis for hypercapnia in the context of the patient's condition. 4. Formulating and implementing an evidence-based management plan that addresses the underlying cause of the elevated ETCO2 and supports adequate ventilation. 5. Continuously reassessing the patient's response to interventions and adjusting the plan as needed. This systematic approach ensures that patient care is guided by data, clinical expertise, and regulatory expectations. Question 3. The efficiency study reveals that physician assistants are spending a significant amount of time on documentation and billing reconciliation. In a specific case involving a patient with newly diagnosed chronic kidney disease, CKD, requiring initiation of a new antihypertensive medication and a urinalysis, the PA has completed the patient encounter and is preparing to finalize the billing. Which of the following represents the most efficient and compliant approach to ensure accurate billing and adherence to regulatory requirements? Option A. Prioritize completing the efficiency study report by submitting the billing without a detailed review, as the study itself is a higher administrative priority. Option B. Thoroughly review the patient's electronic health record to confirm that the urinalysis results, the rationale for the antihypertensive prescription, and the patient's CKD diagnosis are all accurately documented and support the services billed. Option C. Submit the billing immediately to the billing department, assuming they will identify and correct any documentation gaps or inconsistencies. Option D. Delegate the final review of the documentation for billing purposes to a medical assistant, trusting their general understanding of charting requirements. The correct answer is B. Thoroughly review the patient's electronic health record to confirm that the urinalysis results, the rationale for the antihypertensive prescription, and the patient's CKD diagnosis are all accurately documented and support the services billed. Explanation. This scenario is professionally challenging because it requires a physician assistant PA to balance the immediate need for patient care with the administrative and regulatory requirements of managing patient data and billing. The PA must ensure that documentation accurately reflects the services provided, which directly impacts reimbursement and compliance with federal healthcare regulations, such as those enforced by the Centers for Medicare and Medicaid Services, CMS, and the Health Insurance Portability and Accountability Act, HIPAA. Accurate and timely documentation is crucial for demonstrating medical necessity, preventing fraud and abuse, and maintaining the integrity of the healthcare system. The correct approach involves meticulously reviewing the patient's chart to ensure all documented services, including diagnostic tests and pharmacological management, are accurately reflected and align with the patient's clinical presentation and the PA's assessment and plan. This approach is ethically and regulatorily justified because it upholds the principles of accurate medical record keeping, which is a cornerstone of patient safety and legal compliance. It ensures that billing reflects actual services rendered, preventing potential accusations of upcoding or fraudulent billing, and adheres to the documentation requirements mandated by CMS for reimbursement. Furthermore, it aligns with the PA's professional responsibility to maintain comprehensive and truthful patient records. An incorrect approach of submitting the billing without verifying the documentation's completeness and accuracy is ethically and regulatorily flawed. This could lead to improper billing practices, potentially violating CMS guidelines and HIPAA regulations regarding accurate representation of services. It also fails to uphold the PA's professional duty to ensure the integrity of patient records and billing information. Another incorrect approach of prioritizing the completion of the efficiency study over accurate patient documentation and billing is also professionally unacceptable. While efficiency is important, it should not come at the expense of regulatory compliance and accurate patient care representation. This could result in delayed or incorrect billing, potentially impacting practice revenue and leading to audits or penalties from regulatory bodies. It demonstrates a failure to prioritize core professional responsibilities. A third incorrect approach of assuming the billing department will catch any discrepancies is a significant ethical and regulatory failure. PAs are directly responsible for the documentation of their services. Delegating this responsibility without oversight or verification opens the door to errors and potential violations, undermining the PA's role in ensuring compliance and accurate patient care. Professional decision-making in such situations requires a systematic approach. First, prioritize patient care and accurate clinical documentation. Second, understand and adhere to all relevant federal and state regulations governing healthcare documentation and billing, including CMS guidelines and HIPAA. Third, implement a process for verifying the accuracy and completeness of documentation before submitting billing. Finally, communicate any identified discrepancies or needs for clarification to the appropriate personnel, such as the billing department, to ensure timely and accurate resolution. Question 4. System analysis indicates that a 62-year-old male with a 15-year history of type 2 diabetes mellitus, managed with metformin and glipizide, presents for a routine follow-up. He reports increased fatigue over the past month, occasional blurred vision, and a subjective increase in thirst. His last HbA1c was 7.8% 6 months ago. Which of the following represents the most appropriate initial approach for the physician assistant to take in managing this patient? Option A. Prescribe a new oral hypoglycemic agent to address the reported increase in symptoms. Option B. Advise the patient that these symptoms are common with type 2 diabetes and suggest he increase his fluid intake. Option C. Immediately contact the supervising physician to discuss adjusting the patient's current diabetes medications. Option D. Perform a comprehensive physical examination, review the patient's medication adherence, and order laboratory tests including a fasting blood glucose, HbA1c, and basic metabolic panel. The correct answer is D. Perform a comprehensive physical examination, review the patient's medication adherence, and order laboratory tests including a fasting blood glucose, HbA1c, and basic metabolic panel. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient with a chronic endocrine condition, type 2 diabetes mellitus, exhibits signs of a potential complication. Professional challenge lies in accurately assessing the patient's current status, differentiating between expected disease progression and a new, acute issue, and initiating appropriate diagnostic and management steps within the scope of PA practice, all while adhering to established clinical guidelines and the physician assistant supervisory agreement. The need for timely and accurate diagnosis is paramount to prevent further morbidity and mortality. Correct approach analysis. The correct approach involves a systematic and evidence-based evaluation. This includes a thorough patient history focusing on recent symptom changes, a comprehensive physical examination, and the ordering of relevant diagnostic tests such as HbA1c, fasting blood glucose, and potentially renal function tests and urinalysis to assess for diabetic nephropathy or other complications. This aligns with the PA's role in patient assessment and management, as defined by the NCCPA scope of practice and general medical practice principles. The emphasis on gathering objective data and considering differential diagnoses is crucial for effective patient care and aligns with the ethical obligation to provide competent care. Incorrect approaches analysis. One incorrect approach would be to dismiss the patient's symptoms as typical for their known condition without further investigation. This fails to acknowledge the potential for acute complications or worsening of chronic disease, which could lead to delayed diagnosis and treatment, violating the ethical duty to provide diligent care and potentially breaching standards of practice. Another incorrect approach would be to immediately escalate care to the supervising physician for all diagnostic decisions without first performing a thorough PA-led assessment. While collaboration is essential, the PA is trained to independently assess, diagnose, and manage many conditions within their scope. This approach undervalues the PA's expertise and could lead to unnecessary delays in patient care, potentially impacting patient outcomes and not fully utilizing the PA's capabilities as intended by the healthcare team structure. A third incorrect approach would be to prescribe a new medication without adequate diagnostic workup. This is premature and potentially harmful, as the symptoms could be indicative of a complication requiring a different management strategy than simply adjusting current diabetes medication. This violates the principle of evidence-based medicine and could lead to adverse drug events or ineffective treatment. Professional reasoning. Professionals should approach such situations by first activating their clinical reasoning skills. This involves a structured assessment process, gathering subjective information, patient's report, objective data, physical exam findings, vital signs, and then formulating a differential diagnosis. Based on the differential, appropriate diagnostic tests are ordered to confirm or refute potential diagnoses. Management decisions are then made based on confirmed diagnoses and established clinical guidelines, with appropriate consultation or referral as needed. This systematic approach ensures patient safety, promotes efficient use of resources, and upholds professional standards of care. Question 5. The risk matrix shows a high probability of delayed diagnosis and adverse patient outcomes when suspicious dermatological lesions are not promptly and accurately evaluated. A 55-year-old patient presents with a new, irregularly shaped, asymmetrical mole on their back that has changed in color and size over the past 3 months. The lesion measures approximately 8 mm in diameter. What is the most appropriate next step in managing this patient? Option A. Prescribe a topical corticosteroid cream to reduce inflammation and monitor for improvement. Option B. Refer the patient to a dermatologist for evaluation and consideration of a skin biopsy. Option C. Reassure the patient that most moles are benign and schedule a follow-up appointment in 6 months. Option D. Attempt to definitively diagnose the lesion as benign or malignant based on visual inspection alone. The correct answer is B. Refer the patient to a dermatologist for evaluation and consideration of a skin biopsy. Explanation. Scenario analysis. This scenario presents a common clinical challenge in dermatology where a patient exhibits signs and symptoms that could indicate a serious underlying condition, specifically melanoma. The professional challenge lies in accurately differentiating between benign and malignant lesions, which has significant implications for patient prognosis and treatment. The PA must apply their knowledge of dermatological anatomy, physiology, and the specific characteristics of skin cancers to make a timely and appropriate diagnostic and management decision. The risk matrix in this context highlights the potential for delayed diagnosis and adverse outcomes if the condition is mismanaged. Correct approach analysis. The correct approach involves a systematic evaluation of the lesion, considering its morphology in relation to established criteria for skin cancer, such as the uptake of melanoma. Prompt referral to a dermatologist for definitive diagnosis via skin biopsy is the most appropriate next step. This aligns with the PA's scope of practice, which includes the ability to diagnose and manage dermatological conditions, and crucially, to recognize when a condition requires specialist intervention. The NCCPA emphasis on evidence-based practice and patient safety mandates that PAs utilize diagnostic tools and consult specialists when indicated to ensure optimal patient care and prevent harm. This approach prioritizes accurate diagnosis and timely treatment, directly addressing the potential risks identified in the risk matrix. Incorrect approach is analysis. Proceeding with conservative management without further investigation, such as prescribing topical steroids for a suspected lesion, is an incorrect approach. This fails to address the potential for malignancy and delays definitive diagnosis and treatment, increasing the risk of disease progression and poorer outcomes. Ethically, this constitutes a failure to act in the patient's best interest and violates the principle of non-maleficence. It also falls short of the regulatory expectation for PAs to utilize appropriate diagnostic measures. Attempting to definitively diagnose melanoma based solely on visual inspection without a biopsy is also an incorrect approach. While PAs are trained to recognize suspicious lesions, a definitive diagnosis of melanoma requires histological examination. Relying solely on visual assessment can lead to misdiagnosis, either by missing a melanoma or by unnecessarily alarming the patient about a benign lesion. This approach bypasses essential diagnostic steps mandated by best practices in dermatology and regulatory guidelines for diagnostic accuracy. Reassuring the patient and scheduling a follow-up appointment in several months without any further diagnostic steps is an incorrect approach. This delays necessary evaluation and intervention, potentially allowing a malignant lesion to grow and metastasize. This inaction directly contradicts the principle of timely care and patient safety, and it fails to meet the professional responsibility to investigate potentially serious conditions promptly. Professional reasoning. When faced with a suspicious dermatological lesion, the PA should follow a structured approach. 1. Assess the lesion using established dermatological criteria, e.g., uptake. 2. Consider the patient's history and risk factors. 3. Determine if the lesion warrants further investigation or specialist referral. 4. If suspicion for malignancy is present, prioritize obtaining a definitive diagnosis, typically through skin biopsy. 5. Refer to a dermatologist for biopsy and management if the lesion is concerning or falls outside the PA's comfort level or scope for definitive management. 6. Document all findings, assessments, and plans thoroughly. This systematic process ensures that patient care is guided by evidence, safety, and regulatory compliance, minimizing risks and optimizing outcomes. Question 6. Operational review demonstrates a 55-year-old male with a history of Crohn's disease, treated with infliximab and a prior appendectomy, presenting with a 2-week history of worsening abdominal pain, intermittent nausea, and a subjective decrease in appetite. He denies fever, vomiting, or changes in bowel habits. Physical examination reveals mild epigastric tenderness and mild abdominal distension. Laboratory results show elevated alkaline phosphatase and GGT, with otherwise normal liver function tests and complete blood count. His most recent colonoscopy 18 months ago showed mild iletes. Which of the following diagnostic and management strategies is most appropriate for this patient? Option A. Schedule a repeat colonoscopy immediately to assess for active Crohn's disease exacerbation and obtain biopsies. Option B. Refer the patient to a gastroenterologist for further evaluation and management without initiating any immediate diagnostic steps. Option C. Order an abdominal ultrasound to evaluate for biliary or hepatic pathology and consider a trial of increased anti-inflammatory medication for his Crohn's disease if ultrasound is unremarkable. Option D. Initiate empiric treatment for Helicobacter pylori infection, given the epigastric tenderness and nausea. The correct answer is C. Order an abdominal ultrasound to evaluate for biliary or hepatic pathology, and consider a trial of increased anti-inflammatory medication for his Crohn's disease if ultrasound is unremarkable. Explanation. This scenario presents a common clinical challenge involving a patient with a complex gastrointestinal history and new, concerning symptoms. The professional challenge lies in synthesizing the patient's past medical history, current presentation, and diagnostic findings to formulate an accurate diagnosis and appropriate management plan, while adhering to established medical standards and guidelines. This requires a deep understanding of gastrointestinal pathophysiology, diagnostic modalities, and pharmacological interventions. The correct approach involves a systematic evaluation of the patient's symptoms in the context of their known conditions and diagnostic results. This includes considering the possibility of a new or worsening gastrointestinal issue, such as a complication of their IBD, a new diagnosis, or a consequence of their prior surgery. The physician assistant's role is to integrate all available information to arrive at the most likely diagnosis and initiate evidence-based treatment. This aligns with the NCCPA emphasis on the PA's responsibility for patient care, including accurate diagnosis and management within their scope of practice, as outlined in the PANRE blueprint, which covers gastrointestinal disorders extensively. An incorrect approach would be to dismiss the patient's symptoms as solely related to their known IBD without further investigation, especially given the new onset of specific findings like elevated liver enzymes and abdominal distension. This failure to consider alternative or coexisting diagnoses, particularly when objective data suggests otherwise, could lead to delayed or misdiagnoses of serious conditions like biliary obstruction or hepatic dysfunction, potentially violating the ethical principle of beneficence and the regulatory expectation of providing competent medical care. Another incorrect approach would be to immediately initiate aggressive pharmacological treatment for a presumed diagnosis without a clear diagnostic pathway or consideration of the patient's full medical profile. This could lead to adverse drug reactions, mask underlying pathology, or be ineffective, failing to meet the standard of care and potentially violating the principle of non-maleficence. The professional decision-making process for similar situations should involve a structured approach. 1. Thoroughly review the patient's history, including past diagnoses, treatments, and surgical interventions. 2. Carefully assess the current symptoms and perform a comprehensive physical examination. 3. Critically evaluate all available diagnostic data, including laboratory results and imaging. 4. Formulate a differential diagnosis, considering all plausible conditions. 5. Prioritize diagnostic steps to confirm or exclude the most likely diagnoses. 6. Develop a management plan based on confirmed diagnoses and evidence-based guidelines, ensuring patient safety and efficacy. Question 7. Process analysis reveals a 68-year-old male presenting with progressive fatigue, unexplained bruising, and intermittent bone pain over the past 3 months. He denies any recent infections or known bleeding disorders. His past medical history is significant for hypertension managed with lisinopril. On physical examination, he has palpable lymphadenopathy in the cervical and axillary regions and petechiae on his lower extremities. Which of the following diagnostic strategies best reflects a systematic and appropriate initial approach for this patient? Option A. Refer the patient directly to an oncologist for comprehensive workup without initial laboratory testing. Option B. Perform a complete blood count (CBC) with differential, peripheral blood smear review and basic coagulation studies. Option C. Immediately order a bone marrow biopsy and flow cytometry to evaluate for hematologic malignancy. Option D. Initiate empiric treatment for a viral infection and reevaluate in 2 weeks. The correct answer is C. Immediately order a bone marrow biopsy and flow cytometry to evaluate for hematologic malignancy. Explanation. Scenario analysis. This scenario presents a common yet complex clinical challenge for a physician assistant PA practicing in the United States. The patient's symptoms are suggestive of a serious hematologic malignancy, but also overlap with benign conditions. The challenge lies in accurately and efficiently diagnosing the underlying cause, while adhering to established medical standards and ethical obligations to the patient. This requires a systematic approach to differential diagnosis, appropriate diagnostic testing, and timely referral when necessary, all within the scope of PA practice as defined by NCCPA and state regulations. Correct approach analysis. The correct approach involves a comprehensive evaluation that begins with a thorough history and physical examination to gather all relevant clinical data. This is followed by ordering appropriate initial diagnostic tests, such as a complete blood count (CBC) with differential, to assess for abnormalities in blood cell counts and morphology. Based on the initial findings, further targeted investigations, like coagulation studies or peripheral blood smear review, would be indicated to narrow the differential diagnosis. The critical element is the systematic progression from broad assessment to specific testing, guided by clinical suspicion and evidence-based practice. This aligns with the PA's responsibility to provide competent care and to recognize when further specialist consultation is required, as outlined by the NCCPA blueprint for the PANRE and general principles of medical practice. Incorrect approaches analysis. An approach that immediately jumps to ordering highly invasive or specialized tests without a thorough initial assessment and basic laboratory workup is inefficient and potentially harmful. It bypasses the fundamental steps of clinical reasoning and may lead to unnecessary patient discomfort, increased costs, and delayed diagnosis of more common or easily identifiable conditions. It fails to adhere to the principle of judicious use of diagnostic resources. Another incorrect approach would be to dismiss the patient's symptoms as benign without adequate investigation, especially given the potential for serious underlying pathology. This constitutes a failure to meet the standard of care and could result in a misdiagnosis, leading to adverse patient outcomes and potential professional liability. It violates the ethical obligation to thoroughly investigate concerning symptoms. Finally, an approach that involves ordering a battery of tests without a clear diagnostic rationale or a systematic plan is also professionally unsound. This shotgun approach is not evidence-based and can lead to misinterpretation of results, unnecessary anxiety for the patient, and increased healthcare costs. It demonstrates a lack of focused clinical judgment. Professional reasoning. Professionals should approach such cases by first establishing a broad differential diagnosis based on the patient's presenting symptoms and risk factors. This is followed by a stepwise diagnostic plan, starting with the least invasive and most informative tests. Clinical judgment is paramount in interpreting results and deciding on the next steps, including when to consult with or refer to specialists. Adherence to the NCCPA scope of practice and the principles of evidence-based medicine guides this process. Question 8. What factors determine the most appropriate diagnostic and initial therapeutic approach for a patient presenting with symptoms suggestive of a bacterial infection, considering both individual patient outcomes and the broader implications of antibiotic resistance? Option A. The patient's clinical presentation, relevant risk factors, local epidemiological data on common pathogens and their resistance patterns, and established antibiotic stewardship guidelines. Option B. The cost of diagnostic tests and the perceived urgency of symptom relief, prioritizing rapid symptomatic improvement over definitive diagnosis. Option C. The patient's expressed preference for a specific antibiotic, regardless of diagnostic findings or resistance data. Option D. The physician assistant's personal experience with similar cases and the availability of the most commonly prescribed antibiotics in the local pharmacy. The correct answer is A. The patient's clinical presentation, relevant risk factors, local epidemiological data on common pathogens and their resistance patterns, and established antibiotic stewardship guidelines. Explanation. This scenario is professionally challenging because it requires the physician assistant (PA) to balance immediate patient needs with the broader public health implications of infectious disease management, particularly concerning antibiotic resistance. The PA must make critical decisions about diagnostic testing and treatment that impact individual patient outcomes and contribute to the larger fight against antimicrobial resistance, a significant public health concern addressed by federal guidelines and professional standards of care. The correct approach involves a comprehensive diagnostic strategy that prioritizes identifying the causative pathogen and its susceptibility profile. This aligns with the Centers for Disease Control and Prevention (CDC) guidelines on antibiotic stewardship and the NCCPA emphasis on evidence-based practice. By ordering appropriate cultures and sensitivity testing, The PA gathers the necessary data to select the most effective and targeted antibiotic, thereby minimizing the risk of treatment failure, reducing the development of further resistance, and preventing unnecessary broad-spectrum antibiotic use. This approach is ethically sound as it upholds the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, by ensuring appropriate treatment and contributing to public health. An incorrect approach would be to immediately prescribe broad-spectrum antibiotics without definitive diagnostic testing. This fails to adhere to antibiotic stewardship principles, which are integral to PA practice, as outlined by professional organizations and regulatory bodies. Such an approach increases the risk of selecting an ineffective agent, leading to prolonged illness, potential complications, and contributing to the development of antibiotic-resistant organisms. Ethically, this could be seen as a failure of non-maleficence by exposing the patient to unnecessary risks and potentially harming the wider community by promoting resistance. Another incorrect approach would be to solely rely on empirical treatment based on common pathogens in the community, without considering the specific patient's history, risk factors, or local resistance patterns. While empirical treatment has a role, it should be guided by available data and reassessed once diagnostic results are available. Without this, the PA risks misdiagnosis and inappropriate treatment, which can have negative consequences for the patient and contribute to resistance. Finally, an approach that delays diagnostic testing due to perceived time constraints or cost concerns, without a clear plan for timely intervention, is also professionally unacceptable. The PA's responsibility extends to ensuring that diagnostic resources are utilized effectively to achieve the best patient outcomes and public health goals. Delays can lead to worsening infection and increased selection pressure for resistance. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly assess the patient's presentation, including history, physical examination, and risk factors. 2. Consider the most likely differential diagnoses, including common and serious infectious etiologies. 3. Consult relevant clinical guidelines and evidence-based resources, such as CDC recommendations for infectious disease management and antibiotic stewardship. 4. Prioritize diagnostic testing that will yield the most actionable information for targeted treatment, balancing urgency with the need for accuracy. 5. Initiate appropriate empirical therapy if indicated, with a clear plan for de-escalation or adjustment based on diagnostic results. 6. Continuously reassess the patient's response to treatment and adjust the plan as necessary. Question 9. Examination of the data shows a 58-year-old female patient with a history of stage Roman II breast cancer treated with lumpectomy and radiation 5 years ago presents for a routine follow-up. She reports a new palpable lump in her left breast, which she noticed yesterday. She denies any nipple discharge, skin changes, or axillary swelling. What is the most appropriate next step in the management of this patient? Option A. Reassure the patient that given her history, this is likely a benign cyst and no further investigation is immediately needed. Option B. Advise the patient to monitor the lump for any changes over the next 3 months and then schedule a follow-up appointment. Option C. Refer the patient directly for surgical excision of the palpable lump without further diagnostic imaging. Option D. Order a diagnostic mammogram and ultrasound of the left breast, and if findings are suspicious, proceed with a biopsy. The correct answer is D. Order a diagnostic mammogram and ultrasound of the left breast, and if findings are suspicious, proceed with a biopsy. Explanation. This scenario presents a common clinical challenge for physician assistants PA involving a patient with a history of breast cancer and a new concerning symptom. The professional challenge lies in accurately assessing the patient's current condition, differentiating between a recurrence, a new primary malignancy, or a benign condition, and initiating appropriate diagnostic and management pathways within the scope of PA practice and established clinical guidelines. This requires a thorough understanding of breast cancer epidemiology, diagnostic modalities, and treatment principles, as well as adherence to the PA's ethical and legal responsibilities. The correct approach involves a comprehensive evaluation that includes a detailed history, a thorough physical examination, and the judicious ordering of appropriate diagnostic tests. This aligns with the PA's role in patient assessment and management, as outlined by the NCCPA and State Practice Acts, which mandate that PAs provide care within their scope of practice and under the supervision of a collaborating physician when required. Ordering a mammogram and ultrasound, followed by a biopsy if indicated, represents a standard, evidence-based approach to investigating a palpable breast mass in a patient with a history of malignancy. This systematic evaluation ensures that the most likely diagnoses are investigated efficiently and effectively, prioritizing patient safety and optimal outcomes. An incorrect approach would be to dismiss the symptom as benign without adequate investigation, given the patient's significant risk factor. This failure to thoroughly evaluate a potentially serious condition constitutes a breach of the standard of care and could lead to delayed diagnosis and treatment, with potentially devastating consequences for the patient. Another incorrect approach would be to immediately recommend surgical excision without prior diagnostic confirmation. While surgery may ultimately be necessary, proceeding without a biopsy to confirm the nature of the mass is premature and could lead to unnecessary morbidity and expense. Furthermore, it bypasses crucial diagnostic steps that inform treatment planning. Finally, an incorrect approach would be to defer all management decisions to the collaborating physician without performing an initial assessment and formulating a differential diagnosis. While collaboration is essential, PAs are trained to independently assess and manage patients within their scope, and this includes initiating appropriate diagnostic workups for concerning symptoms. The professional reasoning process for similar situations should involve a systematic approach. 1. Recognize the presenting symptom and its potential significance, especially in the context of the patient's medical history. 2. Formulate a differential diagnosis, considering both common and serious possibilities. 3. Determine the appropriate diagnostic steps based on evidence-based guidelines and the patient's risk factors. 4. Initiate diagnostic tests and treatments within the PA's scope of practice and in collaboration with the supervising physician as needed. 5. Continuously reassess the patient's condition and adjust the management plan accordingly. Question 10. When evaluating a 65-year-old patient with a recent diagnosis of hypertension and a family history of glaucoma, who expresses reluctance to undergo a visual field test, stating, "I can see fine, and I don't want to spend more time and money on tests I don't think I need," what is the most appropriate course of action for the physician assistant? Option A. Strongly insist that the patient undergo the visual field test immediately, citing the potential for blindness and making them feel guilty for their reluctance. Option B. Explain the rationale for the visual field test, emphasizing its role in detecting early signs of glaucoma that may not be apparent to the patient, and explore the patient's specific concerns about time and cost. Option C. Respect the patient's wishes and document their refusal of the visual field test, proceeding with routine eye care without further discussion. Option D. Refer the patient to an ophthalmologist for a second opinion, without first attempting to educate them on the necessity of the test. The correct answer is B. Explain the rationale for the visual field test, emphasizing its role in detecting early signs of glaucoma that may not be apparent to the patient, and explore the patient's specific concerns about time and cost. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the PA's clinical judgment regarding the necessity of further diagnostic testing for a potentially serious condition. The PA must balance patient autonomy with the ethical and legal obligation to provide appropriate medical care and prevent harm. The PA's duty of care, as outlined by the NCCPA and State Practice Acts, mandates acting in the patient's best interest, which includes pursuing necessary diagnostic evaluations to confirm or rule out significant pathology. The correct approach involves respectfully but firmly explaining to the patient the rationale for recommending a visual field test, emphasizing the potential benefits of early detection and management of conditions like glaucoma. This aligns with the ethical principle of beneficence, acting for the patient's good, and non-maleficence, avoiding harm. It also upholds the PA's professional responsibility to provide evidence-based care and to educate patients about their health. The PA should document the discussion, the patient's refusal, and the rationale for the recommendation, ensuring informed consent, or informed refusal, is properly managed. An incorrect approach would be to immediately accede to the patient's refusal without further discussion or explanation. This fails to uphold the PA's duty of beneficence and could lead to delayed diagnosis and treatment of a sight-threatening condition, potentially violating the standard of care. Another incorrect approach would be to dismiss the patient's concerns or to be overly dismissive of their autonomy, which could damage the patient-provider relationship and lead to a complaint. Pressuring the patient excessively or making them feel guilty for their decision would also be ethically problematic and counterproductive. The professional decision-making process in such situations involves 1. Assessing the patient's understanding of their condition and the proposed test. 2. Clearly communicating the medical necessity and potential consequences of not undergoing the test. 3. Exploring the patient's reasons for refusal e.g. cost, fear, misunderstanding. 4. Offering alternatives or addressing concerns where possible. And 5. Documenting the entire interaction, including the patient's informed refusal and the PA's professional recommendation. Question 11. The performance metrics show that a 45-year-old male patient presents with a 3-week history of persistent nasal congestion, purulent rhinorrhea, and facial pressure, which has not improved despite a 7-day course of amoxicillin. His initial physical examination revealed mild erythematous nasal mucosa. Given the lack of improvement and the ongoing symptoms, which of the following diagnostic approaches is most appropriate to further evaluate this patient? Option A. Refer the patient immediately to an otolaryngologist for further evaluation. Option B. Recommend a trial of intranasal corticosteroid spray for 2 weeks. Option C. Perform a nasal endoscopy to directly visualize the nasal passages and sinus ostia. Option D. Prescribe a broad-spectrum antibiotic for an additional 10 days. The correct answer is C. Perform a nasal endoscopy to directly visualize the nasal passages and sinus ostia. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with persistent symptoms and a history of prior treatment failure. The professional challenge lies in accurately diagnosing the underlying cause of the patient's ongoing nasal congestion and facial pain, especially when initial management has not yielded resolution. Differentiating between recurrent sinusitis, allergic rhinitis, or other less common etiologies requires a systematic and evidence-based approach, adhering to established clinical guidelines and diagnostic protocols relevant to physician-assistant practice. The need for objective diagnostic data beyond subjective reporting is paramount. Correct approach analysis. The correct approach involves utilizing objective diagnostic tools to confirm or refute the suspected diagnosis of sinusitis. Nasal endoscopy allows for direct visualization of the nasal passages and sinus ostia, identifying inflammation, polyps, or purulent drainage that may not be apparent on physical examination alone. This aligns with the principle of evidence-based practice, which emphasizes the use of diagnostic tests to guide clinical decision-making and ensure appropriate treatment. The NCCPA, National Commission on Certification of Physician Assistants, emphasizes the PA's role in performing and interpreting diagnostic tests as part of their scope of practice, and this scenario directly tests that competency. Incorrect approaches analysis. Recommending a different antibiotic without further diagnostic investigation fails to address the potential for treatment resistance or an alternative diagnosis. This approach risks prolonging the patient's symptoms and contributing to antibiotic overuse, which is a significant public health concern and contrary to responsible antimicrobial stewardship principles. It bypasses the opportunity to gather objective data that could lead to a more definitive diagnosis and targeted therapy. Prescribing a nasal steroid spray without confirming the presence of inflammation or an allergic component is premature. While nasal steroids are effective for allergic rhinitis and some forms of sinusitis, their empirical use without a clear indication may not resolve the patient's symptoms if the underlying cause is different, such as a bacterial infection or anatomical obstruction. This approach lacks the diagnostic rigor expected in managing persistent symptoms. Referring the patient to an otolaryngologist without attempting further diagnostic workup in the primary care setting is an unnecessary escalation of care. While referral is appropriate if initial diagnostic efforts are inconclusive or if specialized intervention is required, it should not be the first step when objective diagnostic tools like nasal endoscopy are readily available and within the PA's scope of practice for evaluating such conditions. This delays definitive management and potentially increases healthcare costs. Professional reasoning. Professionals should approach persistent or treatment-refractory symptoms with a systematic diagnostic process. This involves a thorough history and physical examination, followed by the judicious use of appropriate diagnostic tests to confirm or exclude suspected conditions. When initial treatments fail, The next step should be to gather more objective data to refine the diagnosis before escalating treatment or referral. Adherence to evidence-based guidelines and the scope of practice defined by the certifying body, NCCPA, is crucial for providing optimal patient care and maintaining professional standards. Question 12. Quality control measures reveal that a physician assistant PA, caring for a 4-year-old patient, notes concerning physical findings, including unexplained bruising in various stages of healing and a history of recurrent injuries that seem inconsistent with the child's developmental stage and reported mechanisms of injury. The PA also observes that the child appears withdrawn and fearful when the parents are present. Which of the following actions is the most appropriate and legally mandated response for the PA in this situation? Option A. Discuss the concerns directly with the parents, explaining the potential implications of the findings and seeking their cooperation in addressing the child's injuries before considering any external reporting. Option B. Immediately report the concerns and observations to the state's Child Protective Services Agency, as per mandated reporter laws. Option C. Consult with a pediatrician or other senior physician within the practice to discuss the case and determine a collective course of action before any report is made. Option D. Document the findings thoroughly in the medical record and advise the parents to seek further evaluation for the child's injuries while continuing to monitor the situation. The correct answer is D. Document the findings thoroughly in the medical record and advise the parents to seek further evaluation for the child's injuries while continuing to monitor the situation. Explanation. This scenario presents a professionally challenging situation because it requires the physician assistant, PA, to balance the immediate needs of a potentially vulnerable child with the legal and ethical obligations to report suspected abuse or neglect. The PA must act decisively while adhering to strict reporting protocols, recognizing that failure to report can have severe consequences for the child and legal ramifications for the PA. The core challenge lies in discerning between genuine concern and the need for formal investigation, necessitating a thorough understanding of reporting thresholds and mandated reporting laws. The correct approach involves a direct and immediate report to the appropriate Child Protective Services Agency, as mandated by law. This aligns with the PA's ethical duty to protect the welfare of children and fulfills the legal requirement of a mandated reporter. The PA profession, governed by the NCCPA and state licensing boards, emphasizes patient advocacy and adherence to legal statutes. Prompt reporting ensures that trained professionals can investigate the situation thoroughly, providing necessary intervention and protection for the child if abuse or neglect is confirmed. This proactive stance prioritizes child safety above all else. An incorrect approach would be to delay reporting to gather more definitive proof or to discuss concerns with the parents before reporting. This delay, while perhaps stemming from a desire to avoid unnecessary alarm or to maintain the patient-provider relationship, constitutes a failure to meet the legal obligations of a mandated reporter. State laws typically require reporting based on reasonable suspicion, not certainty. Furthermore, discussing concerns with the parents prior to reporting could alert potential abusers, leading to further harm to the child or the destruction of evidence, thereby compromising the investigation and the child's safety. Another incorrect approach would be to document concerns but not report them, assuming the parents will address the issue. This abdicates the PA's legal and ethical responsibility and places the child at continued risk. The professional decision-making process in such situations should involve 1. Recognizing the signs and symptoms suggestive of child abuse or neglect. 2. Consulting internal institutional policies and state-specific mandated reporting laws. 3. Making a prompt report to the designated Child Protective Services Agency based on reasonable suspicion. 4. Documenting the observations, actions taken, and the report made in the patient's medical record. 5. Cooperating fully with the subsequent investigation. This framework ensures that legal and ethical obligations are met while prioritizing the safety and well-being of the child. Question 13. Regulatory review indicates that a 78-year-old patient presents with a history of multiple falls in the past 6 months, reports feeling dizzy intermittently, and is taking 7 different prescription medications for various chronic conditions. The patient lives alone and expresses a desire to remain independent. Which of the following approaches best aligns with the Physician Assistant National Recertifying Examination PANRE standards for geriatric care and patient safety. Option A. Prescribe a new medication to manage the dizziness, assuming it is the primary cause of the falls, and advise the patient to be more careful when ambulating. Option B. Immediately refer the patient to a neurologist for a complete workup of the falls without addressing the current medication regimen or functional status. Option C. Initiate a comprehensive medication review to identify potential drug interactions and side effects contributing to dizziness and falls. Assess the patient's functional status and home environment for safety hazards, and collaboratively develop a personalized fall prevention plan with the patient and their family, including medication adjustments if indicated and safe. Option D. Advise the patient to discontinue all non-essential medications to reduce polypharmacy, without a formal assessment of their necessity or potential withdrawal symptoms. The correct answer is C. Initiate a comprehensive medication review to identify potential drug interactions and side effects contributing to dizziness and falls. Assess the patient's functional status and home environment for safety hazards, and collaboratively develop a personalized fall prevention plan with the patient and their family, including medication adjustments if indicated and safe. Explanation: this scenario is professionally challenging because it requires the PA to balance the patient's autonomy with the need to ensure their safety and well-being, particularly in the context of potential cognitive impairment and polypharmacy. The PA must navigate the complex ethical considerations surrounding capacity assessment, informed consent, and the prevention of harm, all while adhering to the standards of care for geriatric patients. The correct approach involves a comprehensive assessment of the patient's functional status, cognitive abilities, and medication regimen, followed by a collaborative discussion with the patient and their family regarding fall prevention strategies and medication reconciliation. This approach aligns with the ethical principles of beneficence, acting in the patient's best interest, non-maleficence, avoiding harm, and respect for autonomy. Specifically, the PA must assess the patient's capacity to make decisions about their care. If capacity is intact, the patient's preferences should guide the plan. If capacity is impaired, the PA must follow established protocols for surrogate decision-making, which may involve family members or legal guardians, while still prioritizing the patient's best interests and minimizing risks. The PA's role in medication reconciliation is crucial to identify and address polypharmacy, a significant risk factor for falls and other adverse events in older adults, as mandated by professional practice guidelines that emphasize safe medication management. An incorrect approach that focuses solely on immediate symptom management, without a thorough assessment of underlying causes or patient capacity, fails to address the root of the problem and may lead to inappropriate interventions. This neglects the principle of beneficence and could result in iatrogenic harm. Another incorrect approach that involves unilaterally altering the medication regimen without patient or family involvement, especially if the patient has capacity, violates the principle of autonomy and informed consent. Furthermore, failing to involve family or caregivers when appropriate, or when the patient's capacity is questionable, can lead to a breakdown in communication and a suboptimal care plan, potentially increasing the risk of elder abuse or neglect if underlying issues are not identified. Professional decision-making in such situations requires a systematic approach. First, assess the patient's immediate safety and any acute issues. Second, conduct a thorough geriatric assessment, including cognitive and functional evaluations. Third, engage in open communication with the patient and their family to understand their concerns and preferences. Fourth, develop a multidisciplinary care plan that addresses identified risks, such as falls and polypharmacy, in collaboration with the patient and their support system. And finally, document all assessments, discussions, and the care plan meticulously. Question 14. Risk assessment procedures indicate a 45-year-old patient with a history of bipolar disorder, currently experiencing a depressive episode and a recent relapse in alcohol use, is expressing passive suicidal ideation, stating, "I just don't see the point in going on." The patient denies an active plan or intent to harm themselves, but admits to feeling hopeless. What is the most appropriate immediate course of action for the physician assistant? Option A. Conduct a comprehensive suicide risk assessment, develop a safety plan with the patient, and arrange for urgent psychiatric consultation. Option B. Discharge the patient with a prescription for a benzodiazepine and instruct them to contact their psychiatrist if symptoms worsen. Option C. Focus on managing the alcohol withdrawal symptoms and defer addressing the suicidal ideation until the patient is sober. Option D. Prescribe a new selective serotonin reuptake inhibitor, SRI, to address the depressive symptoms and advise close follow-up with their primary care provider. The correct answer is A. Conduct a comprehensive suicide risk assessment, develop a safety plan with the patient, and arrange for urgent psychiatric consultation. Explanation. Scenario analysis. This scenario is professionally challenging because it involves a patient with a complex psychiatric history, including a diagnosed mood disorder and a history of substance use, presenting with acute suicidal ideation. The PA must balance immediate safety concerns with the patient's autonomy and the need for ongoing, appropriate psychiatric care. The risk of self-harm necessitates prompt and effective intervention, while the history of substance use adds layers of complexity to treatment planning and medication management. The PA's role is to synthesize this information, assess the immediate risk, and initiate a plan that ensures patient safety while respecting their rights and promoting recovery. Correct approach analysis. The correct approach involves a comprehensive risk assessment for suicide, including evaluating the severity of ideation, intent, plan, and access to means, followed by immediate safety planning and referral to a higher level of care if indicated. This aligns with the NCCPA emphasis on the PA's responsibility to recognize and manage psychiatric emergencies, including suicidal behavior. The PA must document the assessment thoroughly and involve appropriate resources, such as a psychiatrist or crisis intervention team, to ensure the patient receives the necessary specialized care. This approach prioritizes patient safety, adheres to ethical principles of beneficence and non-maleficence, and follows established clinical guidelines for managing suicidal patients. Incorrect approaches analysis. Initiating a new antidepressant medication without a thorough suicide risk assessment and a plan for close monitoring is an ethically and regulatorily unsound approach. This could exacerbate suicidal ideation, especially in the initial stages of treatment, and violates the principle of do no harm. It also fails to address the immediate safety crisis, discharging the patient with a prescription for an anxiolytic and instructions to follow up with their primary care physician in 2 weeks without a formal safety plan or referral to psychiatric services is a critical failure. This neglects the acute suicidal risk, potentially leaving the patient in immediate danger and violating the PA's duty to ensure patient safety in emergent situations. Focusing solely on the patient's history of substance use and attributing the suicidal ideation entirely to withdrawal or intoxication, without a comprehensive assessment of the mood disorder and current suicidal risk, is also an inadequate approach. While substance use is a relevant factor, it does not negate the need to address the immediate suicidal ideation and the underlying mood disorder. This approach risks misdiagnosis and delayed or inappropriate treatment. Professional reasoning. When faced with a patient presenting with suicidal ideation, the professional decision-making process should begin with a rapid, yet thorough suicide risk assessment. This assessment should explore the patient's thoughts, intent, plan, and access to lethal means. Based on the level of risk identified, immediate safety measures must be implemented. This may include de-escalation, developing a safety plan with the patient, involving family or support systems, or initiating a higher level of care such as hospitalization or crisis intervention services. Collaboration with psychiatric specialists is crucial for complex cases. Documentation of the assessment, interventions, and rationale for decisions is paramount. Question 15. Process analysis reveals a physician assistant PA is caring for a 78-year-old patient diagnosed with a newly discovered symptomatic brain tumor. The patient, who has a history of mild cognitive impairment but is currently alert and oriented to person, place, and time, adamantly refuses surgical intervention and chemotherapy, stating they wish to focus on palliative care and spend their remaining time at home with family. The PA believes that aggressive treatment offers the best chance for tumor control and improved quality of life, even with potential side effects. The PA is concerned about the patient's capacity to fully comprehend the long-term implications of refusing life-prolonging treatment given their history of cognitive impairment. What is the PA's most appropriate course of action? Option A. Inform the patient that their decision is medically unsound and that the PA cannot ethically support their chosen path, suggesting they seek care elsewhere. Option B. Consult with a neurologist to discuss the patient's prognosis and treatment options, but proceed with the patient's wishes for palliative care without further assessment of capacity. Option C. Initiate the recommended surgical and chemotherapy treatments immediately, as the PA believes these are in the patient's best medical interest, overriding the patient's stated refusal. Option D. Proceed with a formal capacity assessment, involving the patient and their family in the discussion, and if capacity is confirmed, respect the patient's decision to pursue palliative care, documenting all findings and discussions thoroughly. The correct answer is D. Proceed with a formal capacity assessment, involving the patient and their family in the discussion, and if capacity is confirmed, respect the patient's decision to pursue palliative care, documenting all findings and discussions thoroughly. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the perceived best medical interest of a vulnerable individual, compounded by the physician assistant's PA, ethical and legal obligations. The PA must navigate the complexities of patient autonomy, beneficence, and the legal framework governing medical decision-making for individuals with diminished capacity. The core of the challenge lies in balancing the patient's right to refuse treatment, even if that refusal might lead to harm, with the PA's duty to act in the patient's best interest and adhere to established medical standards and legal precedents. The correct approach involves a thorough assessment of the patient's capacity to make informed decisions regarding their treatment. This includes evaluating their understanding of their condition, the proposed treatment, the risks and benefits of treatment, and the consequences of refusing treatment. If the patient is deemed to have capacity, their decision to refuse treatment, even for a serious neurological condition like a brain tumor, must be respected, provided it is informed and voluntary. This aligns with the ethical principle of patient autonomy and is supported by the legal framework that upholds an individual's right to self-determination in healthcare decisions. The PA should document this assessment meticulously, including the patient's reasoning and the PA's findings regarding capacity. If the patient lacks capacity, the PA must then follow established protocols for surrogate decision-making, typically involving a legally authorized representative or advance directive, and act in accordance with the patient's known wishes or best interests. An incorrect approach would be to unilaterally override the patient's refusal of treatment based solely on the PA's judgment of what is medically best. This violates the principle of patient autonomy and could lead to legal repercussions for battery or lack of informed consent. Another incorrect approach would be to proceed with treatment without a comprehensive capacity assessment or without involving appropriate surrogate decision-makers if capacity is lacking. This disregards the legal and ethical requirements for valid medical consent and could result in a breach of professional duty. Finally, abandoning the patient due to the difficult decision-making process is ethically and legally unacceptable. PAs have a duty to provide care and facilitate appropriate decision-making, even in challenging circumstances. Professional decision-making in such situations requires a systematic approach. First, assess the patient's capacity to make the specific decision at hand. Second, if capacity is present, engage in shared decision-making, respecting the patient's informed choices. Third, if capacity is absent, identify and involve the appropriate surrogate decision-maker and advocate for the patient's best interests or previously expressed wishes. Throughout this process, thorough documentation is paramount. Question 16. The efficiency study reveals that a 68-year-old male with a history of hypertension, type 2 diabetes mellitus, and hyperlipidemia presents to the emergency department with new onset substernal chest pressure that radiates to his left arm, occurring at rest and lasting for 15 minutes. He is currently taking lisinopril, metformin, and atorvastatin. His vital signs are stable, and his initial electrocardiogram shows ST segment depression in the anterior leads. Which of the following approaches best reflects current best practices for managing this patient's cardiovascular presentation? Option A. Administer aspirin, a P2Y12 inhibitor, intravenous nitroglycerin, and initiate a high-intensity statin, while continuing his home medications and closely monitoring his cardiac enzymes and ECG. Option B. Order a stress echocardiogram to assess for inducible ischemia and manage his symptoms with oral analgesics until the test can be performed. Option C. Administer a beta blocker and a calcium channel blocker, and advise the patient to rest and avoid strenuous activity until his symptoms resolve. Option D. Increase the dose of his current lisinopril and metformin, and schedule a follow-up appointment with his primary care physician in 2 weeks for further evaluation. The correct answer is A. Administer aspirin, a P2Y12 inhibitor, intravenous nitroglycerin, and initiate a high-intensity statin, while continuing his home medications and closely monitoring his cardiac enzymes and ECG. Explanation: this scenario presents a common challenge in cardiovascular medicine, managing a patient with multiple comorbidities and a new cardiac event. The professional challenge lies in synthesizing complex patient data, prioritizing interventions, and ensuring adherence to evidence-based guidelines while considering individual patient factors. The physician assistant, PA, must navigate potential drug interactions, assess the patient's overall risk profile, and make timely decisions that optimize outcomes and minimize complications, all within the scope of practice and regulatory framework governing PAs in the United States. The correct approach involves a comprehensive assessment of the patient's current presentation, including a thorough review of their medical history, current medications, and recent diagnostic findings. This includes evaluating the severity of the new onset angina, identifying potential triggers, and assessing for signs and symptoms suggestive of acute coronary syndrome (ACS). Based on this assessment, the PA should initiate guideline-recommended medical management for unstable angina, which typically includes antiplatelet therapy, anticoagulation, beta blockers, and statins, while also addressing the patient's pre-existing hypertension and diabetes. This approach aligns with the NCCPA emphasis on the PA's role in patient assessment, diagnosis, and management, and adheres to established clinical practice guidelines for cardiovascular disease. An incorrect approach would be to solely focus on treating the new angina, without considering the patient's existing conditions and medications. For instance, initiating a new medication without assessing for potential interactions with the patient's current antihypertensive or antidiabetic regimen could lead to adverse events, contravening the PA's ethical and regulatory responsibility to provide safe and effective care. Another incorrect approach would be to delay definitive management of the unstable angina while waiting for further non-urgent diagnostic tests, potentially allowing the condition to progress to a myocardial infarction, which would be a failure to adhere to best practices in managing acute cardiac symptoms. Furthermore, making treatment decisions without consulting or collaborating with the supervising physician when the patient's presentation is complex or deviates from typical presentations would also be a regulatory and ethical lapse, as PAs are expected to practice collaboratively and seek guidance when necessary. The professional decision-making process for similar situations should involve a systematic approach. 1. Rapidly assess the patient's stability and identify immediate life threats. 2. Gather all relevant historical and current data, including medications, allergies, and recent diagnostic results. 3. Formulate a differential diagnosis for the presenting symptoms. 4. Consult evidence-based clinical practice guidelines for the suspected condition. 5. Develop a management plan that addresses the acute issue while considering the patient's overall health status and comorbidities. 6. Communicate effectively with the patient, supervising physician, and other healthcare team members. 7. Continuously reassess the patient's response to treatment and adjust the plan as needed. Question 17. Research into the management of chronic pain in primary care reveals varying approaches to patients presenting with subjective pain complaints that are not consistently supported by objective physical examination findings. A physician assistant, PA, is evaluating a patient who reports significant abdominal pain, but a thorough physical examination, including palpation, percussion, and auscultation, reveals no tenderness, guarding, or abnormal bowel sounds. The PA must decide on the most appropriate next steps to ensure comprehensive and ethical patient care. Which of the following approaches best reflects the principles of clinical reasoning and evidence-based medicine within the PA scope of practice? Option A. Acknowledge the patient's reported pain, conduct a detailed history to explore potential contributing factors, e.g., diet, stress, previous surgeries, develop a broad differential diagnosis, and consider judicious diagnostic testing based on the evolving clinical picture and patient risk factors. Option B. Order a comprehensive panel of laboratory tests and imaging studies, including CT scans and MRIs, to definitively rule out any organic pathology, regardless of specific symptom patterns. Option C. Reassure the patient that since the physical examination is normal, the pain is likely psychosomatic and recommend counseling without further medical investigation. Option D. Focus solely on the negative physical examination findings, explaining to the patient that there is no objective evidence of disease and therefore no further medical intervention is warranted at this time. The correct answer is A. Acknowledge the patient's reported pain, conduct a detailed history to explore potential contributing factors, e.g., diet, stress, previous surgeries, develop a broad differential diagnosis, and consider judicious diagnostic testing based on the evolving clinical picture and patient risk factors. Explanation. Scenario analysis. This scenario presents a common yet challenging clinical situation where a patient's subjective report of symptoms, particularly pain, is not fully corroborated by objective physical examination findings. This discrepancy requires a PA to engage in sophisticated clinical reasoning, balancing patient trust and advocacy with the need for objective evidence and differential diagnosis. The challenge lies in avoiding premature closure on a diagnosis, acknowledging the potential for subtle or atypical presentations, and ensuring the patient feels heard and validated, while still pursuing a thorough and evidence-based diagnostic workup. The PA must navigate the complexities of subjective reporting, potential somatization, and the possibility of an underlying organic pathology that may not be immediately apparent. Correct approach analysis. The correct approach involves a comprehensive and systematic evaluation that prioritizes the patient's subjective experience while diligently exploring potential organic causes. This begins with a detailed history, probing for nuances in the pain's character, onset, duration, alleviating/aggravating factors, and associated symptoms. A thorough physical examination, even if initially unremarkable, should be repeated and may include specific maneuvers to rule out common differentials. Crucially, this approach emphasizes the development of a broad differential diagnosis, considering both common and less common etiologies. The interpretation of diagnostic tests should be guided by the differential and the patient's presentation, avoiding over-reliance on negative findings if clinical suspicion remains. Patient education is paramount, explaining the diagnostic process, potential causes, and the rationale for further investigations, fostering a collaborative approach. This aligns with the PA profession's ethical obligations to provide competent and compassionate care, advocate for patients, and practice evidence-based medicine as outlined by NCCPA guidelines for recertification, which emphasize the importance of diagnostic reasoning and patient-centered communication. Incorrect approaches analysis. Dismissing the patient's reported pain solely due to a lack of objective findings is a significant ethical and professional failure. This approach disregards the patient's lived experience and can lead to a breakdown in the therapeutic relationship, potentially causing the patient to seek care elsewhere or delay necessary treatment. It also violates the principle of patient advocacy. Focusing exclusively on psychological etiologies without a thorough organic workup is also problematic. While psychological factors can influence pain perception, failing to rule out organic causes first can lead to misdiagnoses of serious conditions, which is a direct contravention of the duty to provide competent medical care and practice evidence-based medicine. Ordering a battery of expensive and potentially unnecessary tests without a clear diagnostic rationale, driven by anxiety over the subjective report, is inefficient and not aligned with evidence-based medicine principles or responsible resource utilization. It can also lead to patient anxiety and potential iatrogenic harm from the tests themselves. Professional reasoning. Professionals should employ a systematic approach to clinical reasoning, starting with a broad differential diagnosis based on the initial presentation. This involves actively seeking information that supports or refutes each potential diagnosis. When faced with subjective symptoms that lack objective corroboration, the process should involve iterative refinement of the differential. This means re-evaluating the history, forming a more targeted physical examination, and judiciously selecting diagnostic tests based on the most likely etiologies. Patient education and shared decision-making are integral throughout this process, ensuring the patient understands the rationale for each step and feels empowered in their care. This iterative and collaborative approach minimizes the risk of diagnostic error and promotes patient trust. Question 18. To address the challenge of differentiating between cystic fibrosis and bronchiectasis in a patient presenting with chronic cough, dyspnea, and recurrent pulmonary infections, Which of the following diagnostic strategies represents the most appropriate and ethically sound approach for a physician assistant practicing in the United States? Option A. Order genetic testing for CFTR gene mutations and a sweat chloride test, alongside a high-resolution computed tomography (HRCT) scan of the chest. Option B. Proceed with empirical treatment for bronchiectasis based on the patient's symptom profile and a standard chest X-ray. Option C. Rely solely on spirometry to assess for obstructive or restrictive lung patterns and arterial blood gas, AB analysis to evaluate gas exchange. Option D. Utilize chest X-ray findings to identify bronchial wall thickening, and then initiate treatment based on the most likely diagnosis. Correct answer is A. Order genetic testing for CFTR gene mutations and a sweat chloride test, alongside a high-resolution computed tomography (HRCT) scan of the chest. Explanation: scenario analysis. This scenario presents a common clinical challenge where a physician assistant (PA) must differentiate between two chronic, progressive lung diseases with overlapping symptoms. The professional challenge lies in accurately diagnosing the underlying condition to initiate appropriate, disease-specific management, thereby optimizing patient outcomes and preventing complications. Misdiagnosis can lead to delayed or incorrect treatment, exacerbating the patient's condition and potentially leading to irreversible lung damage or increased morbidity and mortality. The PA must apply a systematic approach, integrating patient history, physical examination findings, and diagnostic test results within the established scope of practice for PAs in the United States, as governed by the NCCPA and relevant state practice acts. Correct approach analysis. The correct approach involves a comprehensive evaluation that prioritizes diagnostic modalities known to differentiate between cystic fibrosis and bronchiectasis, considering the typical age of onset and genetic predisposition for cystic fibrosis versus the acquired nature and potential underlying causes of bronchiectasis. This approach aligns with the NCCPA emphasis on evidence-based practice and the PA's responsibility to utilize diagnostic tools effectively. Specifically, genetic testing for cystic fibrosis transmembrane conductance regulator (CFTR) gene mutations is the definitive diagnostic method for cystic fibrosis. Sweat chloride testing is also a highly sensitive and specific diagnostic tool for CF. For bronchiectasis, imaging such as high-resolution computed tomography (HRCT) of the chest is crucial for visualizing bronchial dilation and identifying potential underlying causes like prior infections or immune deficiencies. Arterial blood gas (AB) analysis and spirometry are valuable for assessing the severity of lung dysfunction and monitoring disease progression in both conditions, but they are not primary diagnostic tools for differentiating between them. This systematic, evidence-based approach ensures accurate diagnosis and facilitates appropriate, patient-centered care, adhering to the PA's ethical obligation to provide competent medical care. Incorrect approaches analysis. Relying solely on spirometry and ABG analysis to differentiate between cystic fibrosis and bronchiectasis is insufficient. While these tests assess lung function and gas exchange, they are not specific enough to distinguish between the two conditions. Both diseases can present with obstructive or restrictive patterns on spirometry and varying degrees of hyposemia on ABGs, making them poor discriminators for initial diagnosis. This approach fails to meet the standard of care by not employing definitive diagnostic tools. Focusing exclusively on chest X-ray findings without further investigation is also inadequate. While a chest X-ray may show abnormalities suggestive of lung disease, it lacks the resolution and specificity to definitively diagnose either cystic fibrosis or bronchiectasis and differentiate between them. HRCT is generally required for a more precise assessment of bronchial abnormalities characteristic of bronchiectasis, and genetic/sweat testing is essential for CF. This approach risks misdiagnosis due to the limited diagnostic yield of a chest X-ray in this context. Initiating empirical treatment for bronchiectasis based on symptom presentation alone, without definitive diagnostic confirmation, is a premature and potentially harmful approach. This bypasses the critical step of establishing an accurate diagnosis, which is a fundamental ethical and professional responsibility. Empirical treatment might mask symptoms, delay the correct diagnosis of cystic fibrosis, which has specific genetic therapies, or lead to the use of inappropriate medications, thereby failing to provide optimal patient care and potentially causing harm. Professional reasoning. When faced with a patient presenting with symptoms suggestive of chronic lung disease, the PA should first conduct a thorough history and physical examination, paying close attention to factors like age of onset, family history, recurrent infections, and specific symptom patterns. Based on this initial assessment, the PA should then formulate a differential diagnosis. In this case, cystic fibrosis and bronchiectasis would be high on the differential. The next step is to order diagnostic tests that can definitively differentiate between these conditions. This involves a tiered approach, starting with the most specific tests. For suspected cystic fibrosis, genetic testing for CFTR mutations and slash or sweat chloride testing are paramount. For suspected bronchiectasis, HRCT of the chest is the gold standard for visualization. Spirometry and ABGs are valuable for assessing disease severity and guiding management once a diagnosis is established, but they are not the primary tools for initial differentiation. This systematic, evidence-based approach, guided by the differential diagnosis and the diagnostic capabilities of available tests, ensures accurate diagnosis and appropriate patient management, aligning with the principles of patient safety and quality care mandated by the NCCPA and state licensing boards. Question 19. Analysis of a 68-year-old male with a history of chronic kidney disease, CKD stage 3 and benign prostatic hyperplasia, BPH, presence with new onset of severe right flank pain radiating to the groin and gross hematuria. He denies fever or chills. His current medications include lisinopril and tamsulosin. Which of the following diagnostic strategies is most appropriate for this patient? Option A. Initiate empiric antibiotic therapy for a urinary tract infection and recheck in 48 hours. Option B. Refer the patient directly to urology for cystoscopy without further diagnostic imaging. Option C. Order a renal ultrasound and urinalysis with microscopy. Option D. Increase the dose of lisinopril to improve renal perfusion and manage the pain with NSAID. Correct answer is C. Order a renal ultrasound and urinalysis with microscopy. Explanation. This scenario presents a common clinical challenge involving a patient with multiple comorbidities and a new, concerning symptom. The professional challenge lies in differentiating between the potential causes of the patient's flank pain and hematuria, considering his history of CKD and BPH, and avoiding premature diagnostic conclusions. Careful judgment is required to ensure appropriate and timely diagnostic workup and management, adhering to established clinical guidelines and the PA's scope of practice as defined by the NCCPA and relevant state regulations. The correct approach involves a systematic evaluation that begins with a thorough history and physical examination, focusing on eliciting details about the flank pain, urinary symptoms, and any changes in his CKD management. This is followed by ordering appropriate diagnostic tests, including urinalysis to assess for infection or hematuria, and renal function tests to evaluate the impact on his existing CKD. Imaging studies, such as a renal ultrasound or CT scan, are crucial for visualizing the kidneys and urinary tract to identify potential causes like nephrolithiasis or renal masses. This comprehensive approach aligns with the principles of evidence-based medicine and the PA's responsibility to provide patient-centered care, ensuring that all potential etiologies are considered and investigated appropriately. An incorrect approach would be to immediately attribute the symptoms solely to his known CKD or BPH without further investigation. For instance, assuming the flank pain is simply a worsening of his CKD, without considering other possibilities like a kidney stone or infection, would be a failure to conduct a thorough differential diagnosis. Similarly, focusing solely on the BPH symptoms and prescribing medication, without investigating the hematuria and flank pain, could delay the diagnosis of a more serious condition like bladder or renal cell carcinoma. Another incorrect approach would be to order invasive procedures without first completing less invasive diagnostic steps, potentially exposing the patient to unnecessary risks and costs. These failures represent a deviation from the standard of care and could lead to adverse patient outcomes. The professional reasoning process for similar situations should involve a structured approach. 1. Gather comprehensive patient data, history, physical exam, prior records. 2. Develop a broad differential diagnosis based on the presenting symptoms and patient's medical history. 3. Prioritize diagnostic investigations based on likelihood, urgency, and invasiveness, starting with less invasive and more informative tests. 4. Interpret diagnostic findings in the context of the differential diagnosis. 5. Formulate a management plan that addresses the confirmed diagnosis while considering the patient's overall health status and comorbidities. 6. Continuously reassess the patient's response to treatment and adjust the plan as needed. Question 20. The investigation demonstrates a 68-year-old male presenting to the emergency department with sudden onset of severe chest pain radiating to his left arm, accompanied by diaphoresis and shortness of breath. Initial vital signs reveal a blood pressure of 80/50 mmHg, heart rate of 110 bpm, respiratory rate of 28 breaths/min, and oxygen saturation of 88% on room air. An electrocardiogram (ECG) shows ST segment elevation in the anterior leads. The patient subsequently becomes unresponsive and pulseless. Which of the following approaches represents the most appropriate immediate management strategy for this patient? Option A. Initiate high-quality cardiopulmonary resuscitation, CPR, administer epinephrine, and prepare for defibrillation according to Advanced Cardiovascular Life Support (ACLS) guidelines. Option B. Focus on securing a definitive airway with intubation before starting chest compressions. Option C. Administer a bolus of intravenous fluids while awaiting the results of a chest X-ray. Option D. Continue to obtain a complete blood count, CBC, and cardiac enzyme panel before initiating any resuscitation efforts. The correct answer is A. Initiate high-quality cardiopulmonary resuscitation, CPR, administer epinephrine, and prepare for defibrillation according to Advanced Cardiovascular Life Support (ACLS) guidelines. Explanation: this scenario presents a professionally challenging situation due to the rapid deterioration of a patient in a critical care setting, requiring immediate and decisive action based on established emergency protocols. The physician assistant (PA) must synthesize complex clinical information, prioritize interventions, and communicate effectively under pressure, all while adhering to the scope of practice and established guidelines for emergency medicine. The challenge lies in the dynamic nature of the patient's condition and the potential for rapid decline, necessitating a systematic and evidence-based approach to management. The correct approach involves a structured assessment and management strategy that aligns with established emergency medicine protocols, specifically those pertaining to cardiac arrest. This includes immediate initiation of high-quality cardiopulmonary resuscitation, CPR, prompt administration of appropriate medications, e.g., epinephrine, amiodarone, and consideration of advanced interventions such as defibrillation or transcutaneous pacing, all guided by current American Heart Association (AHA) guidelines, which are foundational for PA practice in emergency settings within the U.S. regulatory framework. The PA's role is to act decisively within their scope of practice, collaborating with the supervising physician and other healthcare team members to optimize patient outcomes. This adherence to evidence-based guidelines and collaborative practice is ethically mandated and legally supported by the NCCPA certification standards and state practice acts. An incorrect approach would be to delay initiating CPR while awaiting further diagnostic tests. This failure to act promptly in a cardiac arrest scenario directly violates the fundamental principles of emergency care and the established protocols for resuscitation. Such a delay would be a significant ethical lapse, demonstrating a disregard for the patient's immediate survival needs and a failure to uphold the PA's duty of care. Furthermore, it would contravene regulatory expectations for PAs to provide timely and appropriate emergency interventions. Another incorrect approach would be to administer medications without a clear understanding of their indications or dosages in the context of cardiac arrest, or to deviate from established ACLS algorithms without physician consultation. This demonstrates a lack of clinical judgment and a failure to adhere to evidence-based practice, potentially leading to patient harm. Ethically, this represents a breach of competence and a failure to act in the patient's best interest. Regulatory frameworks, including those governing PA practice and certification, emphasize the importance of adhering to established protocols and maintaining competency in emergency procedures. A third incorrect approach would be to focus solely on a single potential cause of arrest without a comprehensive assessment and simultaneous resuscitation efforts. For example, solely focusing on a potential respiratory cause while the patient is in full cardiac arrest and not receiving chest compressions would be a critical error. This demonstrates a failure to recognize the immediate life-threatening nature of the cardiac arrest and to implement the universally accepted, multifaceted approach to resuscitation. This is a failure in critical thinking and prioritization, which are essential components of professional medical practice and are implicitly expected by regulatory bodies overseeing PA practice. The professional reasoning process in such a situation should follow a systematic approach. Recognize the emergency, assess the patient rapidly, activate the appropriate emergency response system, e.g., calling a code, initiate immediate life-saving intervention, g. CPR, airway management, administer medications and perform procedures according to established protocols, e.g., ACL's algorithms, continuously reassess the patient's response, and communicate effectively with the healthcare team, including the supervising physician. This structured decision-making process ensures that all critical steps are taken in a timely and organized manner, maximizing the chances of a positive patient outcome while adhering to professional and regulatory standards.